Okay.
We know that pediatrics, the main ethical principle is beneficent paternalism, or what is called parentalism. So the pediatric clinician has an independent obligation to act in the child's best interest. And this takes moral precedence over the wishes of the parents. So in older children, we have what we call assent, whereby once a child is old enough to understand what you are doing, you need to talk to the child and sort of get the child's go ahead with whatever you want to do. In adult medicine, we have what we call pediatrics. Assent and parental permission can be misleading. It gives the impression that if they refuse the permission, or if the child does not assent to the procedure, we cannot carry it out. So this is where the difference is. If a child disagrees to a procedure, once the procedure is in the best interest of the child, we'll go ahead and carry it out anyway. If the parents refuse permission for a procedure, you will still go ahead and carry it out. But you are just asking because you want to bring them to understand what you're going to do for them. And sometimes this is very difficult and it might bring a lot of conflicts, but in all instances, you need to dialogue with the parent and the child so that they come on the same level with you. The reason why we go through assent and parental consent is that we want to show that we have respect for the child. Even though the child may be vulnerable, we also want to acknowledge their developing capacity to make an informed decision. So assent, usually school-age children are the category that we need to seek assent from. So for example, you want to take a blood sample, you want to do take an x-ray, you want to put in an orthopedic surgery device for scoliosis in an 11-year-old. All these things requires giving information and then bringing the person up to speed on whatever it is that you want to do. The implications, the advantages, the disadvantages, and all that. So the information that you present should include the nature and purpose of the therapy, the risk and consequences of having the therapy and not having the therapy, and then alternatives. So this is just similar to what you do with consent. But for assent, the child is usually below the age of 16. In pediatrics, if an adolescent is above the age of 16 years, they can give consent. If the adolescent is less than the age of 16, but is judged to be competent, they can give consent. Then parents can also give consent. An individual or a local authority with parental responsibility can give consent. So let's say a child in a foster home, the foster parents can give consent. And then a court of competent jurisdiction can give consent. Now we have what we call dissent or disagreement, which is the opposite of assent. And pediatric ethics requires that the clinician and the parents override dissent when the proposed intervention is essential. Otherwise, you should always try to solicit the assent of the child. And if there is no harm done, the dissent should be honored, because you are trying to capitalize or trying to develop the child's ability to think for themselves. So in seeking the younger child's assent, you should help them understand their condition, tell them what they can expect, assess their understanding and whether they feel pressured to assent, and then solicit their willingness to participate. However, you also need to let them know that if they refuse, you still go ahead with whatever it is anyway. Now for adolescents, it's a little more complex because sometimes disagreements can arise between the adolescent and the parent. In such instance, you would want to counsel the adolescent separately from the parents in order for them to all come to the same wavelength. In critical illness, in infants, children, and adolescents, you would want to talk to them about their outcomes. Sometimes there might be misunderstanding between the patient, the family, and the medical staff over treatment proposals. And in this kind of misunderstanding, you should always try and come to a middle ground. Now, when you are defining competence in an adolescent, it's important to try and determine whether this adolescent is mentally capable of it is important to determine whether this person is capable of understanding, whether they have the ability to rationalize and reason, and whether they demonstrate intelligence and understanding. And the criteria for establishing competence, you want to find out if they understand the nature of the therapy, the benefits, the risk. If you give them information, whether they are able to understand the information, whether they are able to retain the information and use it to make a decision, and whether the decision is made free from pressure. Usually, if you are unable to assess competence, then you might want to have another healthcare professional to assess and come to a conclusion as to whether this patient is competent or not. So, in the care of critically ill patients, sometimes you may need to define the limits of therapy. For example, a child who is brain dead, how far can you go with your ventilator and your cardiopulmonary resuscitation? So most children who are terminally ill also need to be counseled on the implications of their illness. And sometimes you may need to make a decision as to when to use, limit, or withdraw life-sustaining medical equipment like ventilators and so on. These decisions are not easy to come by. So sometimes you may need the help of a clinical ethics committee. Now, some of the factors that determine what you do is the medical likelihood of a particular outcome. That is the chances of the child pulling through whatever critical illness there is. Then you may also want to consider the burden on the patient and the family. And then religious and cultural. And then you may want an input from the patient when possible. You may be surprised that you may be surprised that the child will have an understanding of it. Actually, don't want any resuscitation in case they have a cardiac arrest. So effective communication is also important in this setting. And the important thing is to choose a conducive setting to explain, to listen to the child's family and then the child themselves, their fears, understanding, expectation. Then you give the medical information, and then also you should be open to discussion, be willing to understand where they are coming from, and also to discuss the way forward. Sometimes you may need to come down to the level of the child in order to explain the situation. If you are unable to do so, it's best to get the help of a clinical psychologist or a palliative care specialist or a child specialist like a pediatrician, so that you really put everything across as it should. So in the West, usually once they come to a consensus, then they would withhold or withdraw the treatment. And this also involves putting in a do not resuscitate order so that if the end of life approaches, there's no resuscitation. And it's important that all these are well documented and communicated to all members of the staff. But of course, the fact that you will not resuscitate doesn't mean that basic life-sustaining measures will be withheld. So something like hydration and nutrition are also important. Okay. So there's this doctrine of double effect in pediatric ethics. The doctrine of double effect holds that an action with both a good and bad effect is morally justifiable if the good effect is the only one intended and the bad effect is foreseen and accepted but not desired. So let me give a very practical example. For example, a child who is terminally ill with cancer and the child is in severe pain, and so you give morphine to the child. But you know that this morphine can also cause respiratory depression, which can lead to the death of the child. So there are two effects of this drug administration. The first effect is pain relief. The second effect is respiratory depression. So assuming you give the morphine and the child dies, the doctrine of double effect says that once the intended action is for the pain relief, which is the good intent, was the reason why you gave it in the first place, your action of giving the morphine, even though it results in the death of the child, is morally justifiable.
Okay.
In such a case, meeting the obligation of relieving suffering is the intended effect. And this outweighs the acknowledged but unavoidable side effects. So choosing medications that adequately relieve symptoms with minimal adverse effects will be ethically preferable. But the obligation to provide comfort at the end of life outweighs the foreseeable occurrence of unavoidable side effects. So in this case, it hastens death, but it is not the primary objective. But if it were the primary objective, then it's not morally acceptable. Okay. So this should not be confused with active euthanasia. In euthanasia, the objective is to end the life of the patient. In the doctrine of double effects, the reason why the medication is being given is to provide comfort and pain relief to the patient. So intentionality is not a psychological state. It is an objective feature of the act itself. So if you are going to give medication for pain relief, the choice of medication, the dosage, the timing, the rules of administration, all these things would help the court to understand what your intention is. Because if you want to give medication for pain relief, the dosage will be different from something that you give in a lethal dose to kill the patient. And so this is usually when you have a situation whereby a patient has died as a result of medication that is given. The court will use a doctrine of double effect to analyze the situation and determine whether it was intended or not. So there are differences between euthanasia and the doctrine of double effect. In active euthanasia, causing death is a chosen objective. On the other hand, doctrine of double effect, the pain relief is the objective. Under the doctrine of double effect, adequate management of pain, anxiety, or air hunger is recognized as an obligation to the dying patient and is provided by careful titration of medications in response to symptoms. But if death occurs sooner than expected, this is accepted. So in both cases of euthanasia and doctrine of double effect, the patient dies, and in both cases, suffering ends. But immediate death is the intended consequence only in the case of euthanasia. So in euthanasia, what your aim is to kill the patient, but with double effect, that's not your primary aim. Okay. Then we move to another thorny area in the care of disabled newborns. Now, a disabled newborn is a newborn who has challenges, either transitioning from in utero existence to um, existence outside the uterus, or they have a disability that needs medical intervention or medical intervention, like a baby who has an esophageal atresia and will need surgery in order to be able to live a full, successful life. And this is governed by the baby door regulation. And this regulation prohibits the withholding of medically beneficial treatments from disabled infants, except under conditions of permanent unconsciousness, futile treatment, or virtually futile treatment. So just to explain this, what this means is that if you are giving treatment to a disabled newborn and that treatment is available, and it is treatment that will have a solution to the child's problem, you should go ahead. Unless the treatment is futile, meaning that whether you give it or not, the outcome will be the same. So let me give an example. So, okay, so this actually came up in the 1970s or thereabouts, whereby a couple had a baby with Down syndrome. And then investigation revealed that the baby had esophageal atresia, meaning that the esophagus ended in a blind pouch. It didn't continue to the rest of the stomach. And so because of that discontinuity, surgery was needed to sort of put them together, take away the blind end and rejoin them so that the gut will be patent. This couple's obstetrician advised them that, oh, once it's a Down's baby, even though esophageal atresia surgery is available, they should just leave the baby alone because the quality of life is not good anyway. And when the baby died, there was a public outcry, and then this is what brought about the baby door regulation. So, for example, if a woman delivers a baby with a brain condition or a neural tube defect, let's say spinal bifida, and you say that, oh, because of the protrusion at the back, the fact that the part of the meninges or the CNS the spinal cord is protruding at the back, the baby is disabled, so you should leave the baby alone to die. This is not acceptable. Whatever medical treatment is available needs to be provided to this newborn, even though it's disabled. Then death and organ donation. We know that there are two criteria for death. And we have the non-heart beating and then the brain death. And in both instances, the parents or guardians will give the consent for organ donation. We don't readily have organ donation going on in our country, but you never know. It's important to know about it. In pediatrics, one very common thing is religious or cultural objections to treatment. And as pediatricians or medical practitioners taking care of children, we need to be sensitive to these cultural differences and religious differences and maintain an attitude of respect for them. And yet, we need to also reiterate the fact that what we are doing is in the best interest of the child. An adult has a decision-making capacity and so has a right to refuse treatment on religious or cultural grounds. However, children have not yet developed that decision-making capacity. And so they are considered to be a vulnerable population. with the right to treatment. In situations where the life of the child is threatened as a result of the objection, then the medical intervention has to go ahead. And it is ethically justifiable despite parental objections. And in such instances, you may need to refer the case to the Pediatric Ethics Committee, whereby they will deliberate on it and then decide. But most of the time, you go according to the medical intervention required to save the life of the child. The problem in our country is that most of the interventions need the help of parents. So, for example, you want to send a child for dialysis because the child has kidney failure. The parents say no, not agree to the dialysis because maybe we think that it's a spiritual illness, or in our family we don't undergo dialysis, or with the kind of religion that we are following, we will not accept it. You know that the dialysis is in the best interest of the parents, of the child, sorry. And so legally, you should go ahead, seek legal backing and go ahead with the dialysis. But the constraint in Ghana is that who will pay for the dialysis? It isn't free. And so you have to come back to the same parents who you are sort of fighting with to pay for it. And so this becomes a big constraint in pediatric practice. So ideally, what you should do is to have the Pediatric Ethics Committee discuss this issue very well, and then bring the parent on board so that the payments can be effective. Otherwise, you are back to square one. The parents say they will not agree. You say this is what is in the best interest of the child. Okay, we don't have money to pay for it. Then what do you do? So that is the big issue in pediatrics sometimes. So we know about the ethics committee and the things that they consider. Usually they look at if there's a decision to be made. They look at the medical intervention you are proposing, let's say the dialysis. Then they look at the patient's preferences. So the medical indications, maybe kidney failure. What would the patients prefer? What is the quality of life like with the dialysis, without the dialysis? Are there any peculiar contextual features in this particular case? So for example, parents do not have money to support ongoing dialysis for life. What do we do? Okay. So these are the things that the ethics committee looks at when they are sitting on any particular issue. Okay. So we'll go on to newborn screening. So newborn screening is the identification of a previously unrecognized disease or disease precursor using tests or procedures that can be conducted rapidly and economically. So for example, a child has congenital hypothyroidism or low levels of thyroid hormone. You can take a blood sample when they are born, they are newborn, and the results will tell you that this child has congenital hypothyroidism. And so you need to treat. So the introduction of the screening should be done in a carefully controlled manner because there are financial, medical, and psychological implications of the screening. And sometimes this screening identifies patients who need treatment, and this helps to prevent certain side effects. But sometimes too, it might be difficult for the parents because, for example, if it tags a child with a certain condition, only to be realized later on that this child doesn't even have the condition, then it becomes an issue. And a persistent ethical issue is whether the screening should be compulsory, routine, or voluntary with the ability to opt out. Okay. But generally, what is decided is that for the newborn screening, depending on what the outcome, what the benefit of the screening is. So for example, congenital hypothyroidism. If you don't pick it up early, this child would become mentally retarded. So looking at the benefits of treatment as against it's not being tested for, this particular test would need to be made compulsory. On the other hand, certain tests which are of undetermined benefits may not necessarily need to be made compulsory. Okay. So let me give an example of the undetermined benefits. So we know that the breast cancer gene can be genetic. Now, this mutation can be tested for early. So if a parent decides that I don't want to have this screening done, then you just need to monitor the child as they grow. And this has no implications for the future because the breast cancer will not develop in the newborn period anyway. And so sometimes some of these things you need to counsel them. So such testing may be deferred until the child has a capacity to make an informed and voluntary choice. All right. Are there any questions? There is another. Any questions? Hey. Are there people here?
Yes, madam, we are here.
Yes.
Madam, there's a question. Madam, how are you?
I'm fine.
Okay, that's my question. I miss you.
All right. So
Okay.
that's
Madam, please. Doctor, please.
Yes, go ahead.
Yeah, please. In case of emergency where you are talking about a legal intervention, how long can you wait for the legal intervention before you carry on?
So what you do in a hospital settings, in pediatrics, we all have the contact of a legal practitioner who helps us in such situations. So for example, you have a child, let's use a very practical example. A child with an HB of 2. You are not going to sit around and wait for the lawyer to pick up their phone before you arrange for the blood. You take blood samples for grouping and cross-matching. You send to the blood bank. And whilst waiting, you give the child oxygen, you give the child IV fluid. It's not as if as soon as the child gets there, the blood will be ready. So once you are making arrangements for the blood, you also make arrangements and contact the legal practitioner. And then they'll secure the court order for you. But in pediatrics, it is always a given that once it's in the best interest of the child, you want to go ahead. The problem arises when, let's say, and I have seen a situation whereby the child was transfused and the child died anyway. You see? So in this case, the child is it the transfusion that caused the death of the child? Is it the condition that was too far-fetched and the child would have died anyway? You see? And so that is why sometimes you don't want to have a very firm stance as if you are fighting with the parents. You want to dialogue with them and bring them to understand your point so that they will now agree to the procedure. Because, like I said earlier, everything will depend on the parents. You take a blood sample, you depend on the parents to send it to the lab, to pay for it, to have the sample run. Here's the situation you're fighting with the parents. So what do? So you have to find a way to bring them to your corner, and then that's to solve the problem.
Okay.
Are you okay?
Yes, please. So please, does it mean that every facility is supposed to have pediatric ethic committee?
Yes, every facility. But if you are a one-man station, maybe you can.
You are the committee.
Yes, you can form your committee. Get your senior nurse and get a few people, clinical psychologists, one or two lay people, maybe the pastor in the place the chief imam in the town, and then you have your local pediatrics committee, ethics committee. Yeah.
All right.
Okay.
Thank you.
Any other questions?
No,
No,
madam,
please.
my problem with these Jehovah Witness people who doesn't take blood and all that. So in case of a situation like this, how do you go about it? Because when a child is born, and as you said, the child needs an urgent blood, and maybe the medical, the practitioner, the lawyer or whoever you have to contact is not available, and that child needs an urgent blood. And here's the case, the parents are not agreeing.
You have to go ahead and transfuse the child. But like I'm saying, you have to try and get them to agree. If you try your best, you counsel them, you give them the pros and cons, and they are still adamant, then you go ahead. But then you see, when you go ahead, it means that the cost of the processing of the blood and everything should be borne by the facility. And unfortunately, the problem with pediatrics is that we do not have such free services available. You see, so if let's say you send the blood to the blood bank and the blood bank says that pay 150 Ghana for processing fee, you the practitioner, you don't have the 150 cedis. The parents are unwilling to pay. So what will happen? That's the problem. And you have to look for the money and do the transfusion because the parents are adamant. It's not as if the government has provided some money somewhere that when it happens that way, you go and sign for it and give the blood. It becomes a very difficult situation. So in most instances, you have to dialogue with the family. Maybe call somebody else, a grandmother or something, some other relative who will be willing to go ahead with the treatment that is being required.
Thank you.
Yeah.
Okay, madam, good evening.
Evening.
Please, I have a question.
Please go ahead.
This afternoon, I witnessed something in my facility.
Okay.
There was this patient that came in with asthma, and he was on a ventilator, like the oxygen ventilator. And after just about, let's say, 3 minutes, another one, they rushed another one in, who was actually in like respirational distress, like to me. So the PA there took the oxygen from the asthmatic patient and placed it on the one having the respiratory distress. And I told him, and I asked him that, why did he do that? He told me that to his discretion, he did what was best, but he didn't explain anything.
But he did.
To me, he did. He said to his discretion, he's doing what is best.
Yeah.
But me, my discretion, I think like first come first serve. The person who is having asthmatic attack, who has been on it just for let's say 2 minutes, should continue being on it. Like I don't know how that thing works. Can you explain?
And then the new person should want to die.
No, not to die though, but at least almost half.
So it's discretionary. Yes, it's discretionary. And then, hey, who is that?
Madam.
Maybe it's the pastor, that pastor guy on the platform that using that small phone. Galaxy One.
Let me answer the question.
You like talking. You like talking.
Oh, leave the who is calling you.
Hey, we have 4 minutes more. Let me answer the question.
Madam, yes, I'm listening. Don't mind that.
So we have several factors that will determine who gets the oxygen and who doesn't. So for example, if the patient with asthma comes in and you nebulize and you put on oxygen and he's getting better, you may use your discretion and decide that, okay, this new person who is coming is in dire need of the oxygen, needs it more than the asthmatic. Okay, so it is always discretionary. Then there is also the determination of prognosis. If the person who comes in really bad is already far gone, somebody might decide that's okay, well, he's already dead anyway, so there's no need to do anything. This is where social justice comes in. You have very finite resources, limited resources, and you have to make a decision as to who deserves the resources or not. A lot of the time, prognosis is what is used to determine who should be put on the very scarce resources and who should be taken off. And like the PA told you, it's discretionary, actually. And the determinant of that discretion is the prognosis, you see. So in this COVID era, for example, at the initial stages, I heard things like, well, the older people will be taking off and the younger people will be left on. Things like that. There isn't any laid down criteria as to who should get the ventilator and who shouldn't. It's actually one of your exam questions.
Hey.
Madam, say what?
Madam, say it. Madam, say it again.
Madam, repeat it. Madam, repeat it.
No, I want
Madam, if you don't repeat it, your data will go off. Please repeat it.
In fact, we have just about 2 minutes to go.
Oh, Doc, please.
Madam, we'll enter again. We'll enter again. Our ESN examination does not.
Yeah, I know. That's why I said the exam. That's why I said it, so that I'll see people's reaction, because I knew that the moment I say exam, everybody sits upright.
Madam, who's your yes?
Oh,
I
have a question. Danny, not more question.
Yeah.
Question I answer this question and I mean
My soldier,
Christian.
Dog, please, good
How
evening.
is Lebanon?
Oh, Lebanon is good, Doc.
Are you in zero alpha? What's your position?
4-2, I'm at 5-42.
5-42. Oh,
Yes,
okay.
Doc.
You know, I was in Lebanon.
Yes, Doc.
1 year. I was in zero alpha.
Yes, Doc.
Yeah, go ahead with your question. Sorry.
Yes, Doc. We know that in these days, law is evolving in a very rapid way. Is there any bill, any CI, any LI that is circumspect on what you said in terms of a health committee in terms of you taking a decision as a physician with your committee for a child? Is there any law backing it emphatically?
So if the main underlying tenets are the action should be in the best interest of the child, and then there's a recognition of the role of the ethics committee. So once a decision is in the best interest of the child, you are covered.
Okay.
Yes.
Okay.
And usually the Medical and Dental Council, if there's any disputes, they are the final determining body. And they would also go with the fact that it is in the best interest of the child.
Okay, Doc, my follow-up question is this. Now, if I opt as a parent against a decision which is taken by the health practitioners, and it results in maybe a secondary